Namaste all. I, JVM Dr. Ravi Jain, Associate Professor and HOD, Department of Practice of Medicine, in Faculty of Homeopathic Science at JYOTI VIDYAPEETH Women's University, Jaipur. On 19 September 2023, that is Tuesday, I am going to deliver a lecture or I am going to discuss with you various thyroid disorders that I'm covering for BHMS 4th year students. So today we are going to discuss about various thyroid disorders. What are thyroid? What is the thyroid gland? Where it is situated? What is the normal gland? What are the functions of thyroid gland? What are the hormones that are secreted by the thyroid gland? Plus, we are also going to discuss about hypothyroidism and hyperthyroidism. So in this lecture, we are going to cover all these details. What is thyroid gland? Thyroid is derived from the Greek word thyros, that means shield, plus eidos, that means form. Thyroid gland consists of two lobes that are connected by isthmus. The thyroid gland is located anterior to the trachea and between the cricoid cartilage and suprasternal notch. The normal size of the thyroid gland is 12 to 20 gram in size, and it is a highly vascular organ. The thyroid gland is soft in consistency, and we have to remember one important landmark while doing the surgery of the thyroid gland, that is, the recurrent laryngeal nerve traverses through the lateral borders of the thyroid gland. So, in case of thyroidectomy, there can be resection of the recurrent laryngeal nerve. This thing we have to remember. The thyroid gland usually develops from the floor of the primitive pharynx during the third week of gestation. The developing gland migrates along the thyroglossal duct to reach the final location in the neck. Due to various immune disorders, now thyroid gland is secreting two hormones, that is T3 and T4. T3 is known as triiodothyronine and T4 is known as thyroxine. The important function of thyroid gland is cell differentiation during the development, and it helps in maintaining the thermogenic and metabolic homeostasis in the adult. Now, there are various autoimmune disorders of the thyroid gland that can lead to the overproduction of the thyroid gland, that will lead to the production of excessive T3 and T4, and the term for that is known as thyrotoxicosis. Or there can be glandular destruction and hormone deficiency, that is known as hypothyroidism. The benign nodules and various forms of thyroid cancer are relatively common. Now let us first of all discuss about hypothyroidism. What is hypothyroidism? Hypothyroidism is a condition when the thyroid gland fails to produce hormones T3 and T4. Now, let us go to the definition of hypothyroidism. Hypothyroidism is a common condition with various causes, but autoimmune disease, autoimmune when our own immune system is destroying the gland or the cells of the body. And the autoimmune disease that is also known as Hashimoto thyroiditis and thyroid failure after iodine 131 treatment in case of thyrotoxicosis is done. So if a patient of thyrotoxicosis is coming to you, that is hyperthyroidism, and you are treating that patient with the surgery with iodine 131, then the patient can develop autoimmune hypothyroidism, where the glands of the thyroid gland have been destroyed by the own cells of the own immune system. This accounts for around 90% of the cases. Now, based on the causes of hypothyroidism, hypothyroidism can be of three types. Number one, primary. Number two, transient. And number three, secondary. Primary, when the disease is the cause in itself. Transient, when the hypothyroidism is occurring for a small period of time. And secondary, when it is because of any other disease. Now, what are the causes of primary hypothyroidism? There are various causes of primary hypothyroidism that includes autoimmune hypothyroidism, number one. Second is iatrogenic, that is treatment associated. Third can be because of the drugs. Fourth is congenital hypothyroidism. Fifth is iodine deficiency, and sixth is infiltrative disorders. So the primary hypothyroidism, it consists of following types: autoimmune, iatrogenic, drugs, congenital, iodine deficiency, and infiltrative disorders. Now, the autoimmune hypothyroidism can be because of Hashimoto thyroiditis or atrophic thyroiditis. The iatrogenic that I have just discussed with you, that is a treatment of thyrotoxicosis by iodine 131. Subtotal or total thyroidectomy external irradiation of the neck like lymphoma or the cancer, and various antithyroid drugs. Congenital hypothyroidism consists of absence or ectopic thyroid gland, dysharmonogenesis, or TSH receptor mutation. Iodine deficiency is itself a cause of hypothyroidism, and infiltrative disorders like amyloidosis, sarcoidosis, scleroderma, and renal thyroiditis. Transient hypothyroidism means when the hypothyroidism is of small duration, that is, a patient was not suffering from hypothyroidism, but for the short period of time, the patient is now suffering from hypothyroidism. So it can be transient, that is because of the short interval of time. It can be silent thyroiditis that includes postpartum thyroiditis, that is thyroiditis developing after delivery. It can be subacute thyroiditis. Subacute thyroiditis that occurs because of the withdrawal of thyroxine treatment in individuals with intact thyroid, or after iodine 131 or subtotal thyroidectomy for the Graves' disease. Now, secondary hypothyroidism. Secondary hypothyroidism occurs because of some other disease condition leading to hypothyroidism. The condition includes hypopituitarism and hypothalamic diseases. In hypopituitarism, there can be tumors due to surgery or irradiation with infiltrative disorders or Sheehan syndrome or trauma. The hypothalamic disease can occur because of the tumors, trauma, infiltrative disorders, or it can be idiopathic. Now, what are the symptoms of hypothyroidism? Suppose a patient of hypothyroidism is coming to you. How can you diagnose or how can you identify the patient of hypothyroidism? The symptoms of hypothyroidism are tiredness and weakness. The person always remains tired or weakened. The skin remains dry. There will be feeling of cold, that is a lack of vital heat that leads to the feeling of internal cold. Hair loss can be there and difficulty in concentrating and poor memory. The patient is usually constipated and there can be weight gain with poor appetite. There will be dyspnea, that is difficulty in breathing, hoarseness of voice, menorrhagia. Initially there is menorrhagia and later on it becomes oligomenorrhea or amenorrhea. There can be paresthesias or hearing impairment. So the symptoms of hypothyroidism includes tiredness or weakness, dry skin, feeling cold, hair loss, difficulty in concentrating and poor memory, constipation, weight gain or poor appetite, dyspnea, hoarseness of voice, menorrhagia, paresthesia, and impaired hearing. Now there will be certain signs of hypothyroidism. Signs are the features by looking at which you can identify that the patient is having hypothyroidism. The signs of hypothyroidism includes dry, coarse skin. The skin becomes dry and coarse. There will be cool peripheries. The extremities will be cool. There will be puffiness of the hands and feet. That is known as myxedema. And there will be diffuse alopecia. That is hair loss. The heart rate of the patient will be low. That is known as bradycardia. That is pulse rate below 60 per minute. There will be peripheral edema. And there will be delayed tendon reflex. The patient will also be suffering from carpal tunnel syndrome and serous cavity effusion. So the signs of hypothyroidism includes dry skin, dry coarse skin, cool peripheral extremities. There will be myxedema, that is puffiness of face and hands and feet. There will be diffuse alopecia, bradycardia, peripheral edema with delayed tendon reflex relaxation, carpal tunnel syndrome, and serous cavity effusions. Now, there is another term that is known as congenital hypothyroidism. Congenital hypothyroidism occurs when the child is suffering from hypothyroidism by birth. It occurs in around 1 in 4,000 newborn individuals, and this occurs because of the thyroid gland dysgenesis. What is thyroid gland dysgenesis? Dysgenesis means when the thyroid gland fails to develop. There are inborn errors of thyroid hormone synthesis that is seen in around 10 to 15% of the individual, or TSH receptor antibody mediated in 5% of the cases. Now, what are the clinical manifestations of congenital hypothyroidism? When a child is having hypothyroidism by birth, the individuals or the infants appear normal at the time of birth, but there can be prolonged jaundice and feeding problem in the newborn. The muscles will be weak, that is known as hypotonia, and there will be enlarged tongue. There will be delayed bone maturation as well as umbilical hernia. The diagnosis of congenital hypothyroidism can be done by neonatal screening program based on TSH or T4 levels by heel prick test. Heel prick means you are taking the blood sample from the heel of the child. The treatment includes institution of the T4 hormone. That is, T4 has to be given to the child in the proportion of 10 to 15 microgram per kilogram per day. There is another term that is known as autoimmune hypothyroidism. Autoimmune hypothyroidism that we have just now discussed, that autoimmune hypothyroidism occurs because of the destruction of the thyroid gland by the antibodies of the body. Now, autoimmune hypothyroidism is associated with a goiter that is known as Hashimoto or goitrous thyroiditis, or a minimal residual thyroid tissue that is known as atrophic thyroiditis. There can also be subclinical hypothyroidism, where the hypothyroidism is there, but there are no symptoms in the patient, and clinical hypothyroidism or the overt hypothyroidism. Now, what is the prevalence of autoimmune hypothyroidism? The prevalence of autoimmune hypothyroidism ranges from 4 per 1,000 women and 1 per 1,000 men. So, females are more commonly affected by autoimmune hypothyroidism by the ratio of 4:1. Now, what is the pathogenesis? In the pathogenesis, there is marked lymphocytic infiltration. As we know that this is autoimmune disorder, so the immune cells of the body are going to attack the thyroid tissue. So there will be marked lymphocytic infiltration of the thyroid gland with atrophy of the thyroid follicles. In absence of colloid and mild to moderate fibrosis occurs. Now, the clinical manifestations. The clinical manifestations of autoimmune hypothyroidism vary from person to person. But the onset is usually insidious, that is, there is slow onset of the disease condition. The goiter may not be large, but the gland is usually irregular and firm in consistency. The skin is dry. The skin becomes dry and there is decreased sweating. As we have seen in case of hypothyroidism, the skin remains dry and there is thinning of the epidermis and hyperkeratosis of stratum corneum is seen. There is increased dermal glycosaminoglycans. Glycosaminoglycans are the substances that trap water and are responsible for development of myxedema. Puffy face and edematous eyelids and non-pitting peritibial edema is seen. Now, the clinical features of the autoimmune hypothyroidism includes the paler face. The face becomes pale with a yellow tinge to the skin. That is due to carotene accumulation. So there is accumulation of carotene in the body. The nail growth is retarded. The nails do not grow properly, and the hair becomes dry and brittle, and due to the and difficult to manage, and they fall easily. So the nails are becoming brittle and they are falling easily and difficult to maintain. There will be thinning of the outer one third of the eyebrows. These outer one third of the eyebrows they become thin, and there is hair falling from the eyebrows. The patient complains of constipation. There is weight gain. Weight gain is a common feature of hypothyroidism, despite a loss of appetite. Libido is lost or decreased in both the sexes, and the patient complains of menorrhagia, and due to which the fertility is reduced and there is increase in the miscarriage chances in a female. The heart rate decreases, because of which we have seen that there is bradycardia in case of hypothyroidism. The pulse rate and the is reduced below 60, and that is known as bradycardia, leading to the reduced stroke volume and bradycardia. There is increased peripheral resistance with diastolic hypertension. So, patient of autoimmune hypothyroidism develops diastolic hypertension. So, the lower blood pressure is increasing. The blood flow is directed from the skin, producing cold extremities. Hands and feet are cold in an individual, and the fluid may accumulate in the other serous cavities in the middle ear, giving rise to conductive deafness. So the patient also complains of conductive deafness in the autoimmune hypothyroidism. Now, how to identify the case of autoimmune hypothyroidism? The lab test or lab evaluation, we are going to check for the levels of T3 and T4. Naturally, this is a hypothyroidism case, so the levels of T3 and T4 will be less. And we are also going to demonstrate the TPO antibodies, that is thyroid peroxidase antibodies, that will confirm that the patient is suffering from autoimmune hypothyroidism. The fine needle aspiration biopsy shall be done to confirm the presence of autoimmune thyroiditis. Ultrasound of the thyroid gland can be done, and in this way, we can identify that the patient is suffering from autoimmune hypothyroidism. The differential diagnosis includes an asymmetrical goiter in Hashimoto thyroiditis. It can be confused with multinodular goiter. Multinodular goiter or thyroid carcinoma that is usually seen in case of hyperthyroidism. Now, there are other causes of hypothyroidism also that we should know. One is iatrogenic hypothyroidism. Iatrogenic means after treatment of any kind. So the hypothyroidism occurs in first 3 to 4 months after radioiodine treatment for thyrotoxicosis. Transient hypothyroidism may occur to reversible radiation damage. Because of the TSH levels are suppressed by hyperthyroidism, the unbound T4 levels are better measured for thyroid function. The other cause includes iodine deficiency that we have discussed in the very beginning, that low iodine content is responsible for low thyroid hormone formation, and this is responsible for development of endemic goiter. Endemic goiter means the goiter that is remaining in a particular area for the year around. Now we come to secondary hypothyroidism. We have discussed about primary, we have discussed about iatrogenic, and now we are coming to secondary hypothyroidism. In the secondary hypothyroidism, the other organs are responsible for the low thyroid hormone production from the pituitary gland. The secondary hypothyroidism occurs due to other anterior pituitary hormone deficiencies. The TSH level may be low, normal, or slightly increased. The diagnosis is confirmed by detecting the unbound T4 level. For the lab investigation of hypothyroidism, we have to measure the thyroid hormone, especially T3, T4, and TSH. TSH is more important for diagnosis of hypothyroidism. The test to determine the etiology of the thyroid dysfunction includes circulating antibodies against TPO, that is thyroid peroxidase, and thyroglobulin. We also have to check for radioiodine uptake and thyroid scanning that includes radioisotopes of iodine, iodine 123, 125, 131, and technetium 99. And we can also go for thyroid ultrasound. Now, what is the management of hypothyroidism? Whenever a patient of hypothyroidism is coming to us, we have to give thyroxine from outside for the management of hypothyroidism. So daily replacement dose of levothyroxine has to be given, usually 1.6 microgram per kg of body weight. The presence of thyroid autoantibodies in a euthyroid patient is also associated with miscarriage and preterm delivery. So this was all about hypothyroidism. I hope you have understood the hypothyroidism and the concept of hypothyroidism. We have discussed what is hypothyroidism, what are the different causes of hypothyroidism, where we have discussed about primary, transient, and secondary hypothyroidism. We have discussed about the causes of primary hypothyroidism that included autoimmune hypothyroidism, iatrogenic drugs, congenital iodine deficiency, and infiltrative disorders. We have discussed about the transient hypothyroid disorders that include silent thyroiditis and subacute thyroiditis. We also have discussed about the secondary causes of hypothyroidism that includes hypopituitarism and hypothalamic disorders. So this was all about hypothyroidism. We also have discussed about the clinical features, investigation, and management of the same. And I hope you must have understood this session properly. If you have any query, you can write in the comment box, and we can discuss about it in the next class. In the next lecture, we will be discussing about thyrotoxicosis or hyperthyroidism. So this was all for today, and we will be meeting in the next lecture with hyperthyroidism or thyrotoxicosis. So thank you very much. Have a good day.